All right, great. Welcome, everybody. So today we're going to talk about tibia fractures, and as usual, if you want to interrupt me, just say it, whatever you want, and if you want to correct me. Just one second. Okay, so for tibia fractures, for me, I grew up in Prince George's County, so tibia fracture for me is Joe Theismann. I mean, the poor guy suffered a tibia fracture at Lawrence Taylor's sack. So they can be devastating injuries. And Joe Theismann, that was his last game. Anybody here a Joe Theismann fan? No? All right. Everybody's Ravens fans. You know the guy that took care of him? I'm surprised he didn't go back to football. Huh? I would think he'd go back. Like in a year, he should be.
No one. It's very, very rare for a tibia fracture to get back.
For a tibia shaft, for a football player to get back?
Any football player.
Really? Why?
Well, I just can't do it.
Interesting.
Did you see that high ankle sprain on that guy from New England, Bronze or something? He came back, but then he's out again.
All right, so let's start with remember, I'm going to post everything on the internet, so keep your comments PG rated, PG-13 rated. So this is the first case. It's nice to start with the case because it helps you think. So Mark will be the discusser. It's a 58-year-old man who had a right leg injury, 5/29/11. He slipped and fell. He lost consciousness at the party. He said it was Harford County, they drink. And he was outside. It was like a July day. It was like 100 degrees. He said he had 4 or 5 beers, and then stopped drinking. And then he stopped drinking water too, and he just lost consciousness from dehydration. So they worked him up for all that, and he has this injury. So they call you from the ER, and they say, the guy's got a leg fracture. What do you do? Healthy guy otherwise.
I would want to know if it's open or closed. Get full
Closed. Full x-rays are right here. He is neurologically intact.
And I would go in and probably look at him just to make sure he doesn't have compartment syndrome. And
how many years out from practice are you now? I'm just curious, because I never go in.
2.5.
2.5. You're good. You're a good doctor. You're conscientious. That's good. So those are the full length. I have another view, but that's all I have.
Distal oblique shaft and associated fibular fracture. So he's going to need some type of definitive surgery.
He's an active guy. He's a manager for a construction firm. So he's not a laborer, but he's very active. He has to walk. He has to walk the site, things like that.
So I would get him set up to do a tibial nail. Looks like you've got a distal piece to be able to do it.
Okay. Would you treat this? Would you treat this in a cast? Okay. And I'm just curious. Just tell me why.
I mean, it's almost a fracture of necessity in an adult because you're not going to have much remodeling because it's such a cortical bone.
It'll be really morbid in a cast. I mean, but it would heal, but it'd be very morbid and hard to get a good reduction too. Okay. So you nail them when you nail them. Next day, next week, put them on the add-on schedule.
I mean, you could do it that day or the next day.
Next week.
I wouldn't wait.
Okay. So, anybody would do anything different? Doug?
As far as nailing, there was sort of some data showed that it'd do better if you wait a day or two.
Let the soft tissues calm down?
Yeah. But I don't know how long he's been waiting. But
well, let's just we're doing this for fun.
There's no downside of waiting like a day or two for a tibia fracture. Number one. Number two, I would give serious consideration to treating him non-operatively.
So what do you tell him?
If you read the literature, an isolated tibia fracture is kind of like an isolated humerus fracture. Non-operative treatment is...
And you can see the shape of this. This is like a twist. You can see how it's oblique. That's a low energy injury. So that periosteum is probably not torn much. So it should heal well.
I don't think he'd be faulted either way. But it's not reduced. I think if it's reducible, I think it's treatable non-operatively. But I think that there's a consensus of people that want to have their fracture reduced anatomically and treated operatively. So I could go either way.
Okay, so non-operative is a treatment. You could discuss it.
If he had no insurance, he would be treated non-operatively.
No.
And he would probably do pretty well.
It depends what hospital you go to. Most of the hospitals have structured contracts with orthopedic surgeons where they pay them like Medicare rates or something to do surgeries, and most orthopods would fix it because we're like monkeys. We like to fix things and work with things. So, but you're right. Don Juan, what do they do in China?
Probably consulting.
Cast?
Yeah.
Okay.
Bamboo.
Bamboo with
No,
rope.
maybe not do that.
Okay. So I basically, I try to get rid of these things right away. I don't like to send them home just because it's different. Once the patient goes home, they're miserable. I'd like to just get it over with, and I usually do them the next day. So I'm not sure. I would never come in on a Sunday because my wife would kill me. I only use that for true emergencies. So the only thing in my mind was I was sure I had to get this distal guide wire center because of the how distal this tip is. It's not super distal, but it is distal. Come in, Bill. Welcome, Bill. Come in. Bill, this is the first case as a 58-year-old man with a tib-fib fracture. See it? So there's the starting point. There's the distal nail. I did this with Don Juan on the table, just with just poor Don Juan holding it, so he had to get his hands irradiated, reducing the fracture. And here he is post-op. Any questions or comments? Looks all right. Is it in a little valgus, you guys think? No? Okay. And here he is post-op. He came back 7 months, no pain, and you can see how it healed completely. So this is kind of a standard case. So this will be a review of tibia fractures, which is a very important injury for us to take care of.
When did you start in weight bearing here, just out of curiosity?
I'm partial weight bearing immediately, and I put him in within 2 weeks in a boot, and then full weight bearing in a month, because I think it helps to stimulate. And I think it's real important to get people back to their lives, because if they focus on the injury, higher probability, I think, of RSD or complex regional pain syndrome. Those are my thoughts anyway. So tibia fractures, there's 500,000 a year, which is amazing. I was kind of amazed by that. 500,000 a year, and a quarter of them are open. And you could imagine, hey Jack, good morning. A bumper, they commonly are from bumper strikes, and you can imagine the amount of trauma that occurs on a bumper strike. And associated injuries are, the femur can be associated, which is like a floating knee. Fibula, obviously. 2% of them have vascular injuries, and 2% of them have knee ligament injuries. So 1 out of 50 go to Mark so he can reconstruct the ACL or whatever he does. Neurological structures could be injured. This is a cartoon of the deep perineal nerve. So, patient kind of shows where he feels the abnormal symptoms. You can fracture your foot and you can get a compartment syndrome. So the priorities are obviously ABC if you're in the field. If it's open, give the patient tetanus and antibiotics immediately. Reduce it and splint it. On examination, the reason why it's always open is there's no skin on your shin. You can feel your bone all the way around. There's like just skin. There's no muscle. So the bone cuts out of the skin very easily. The other thing is if you're concerned about the pulse, and if the patient nurses say they can't find an obvious pulse, next step's an ankle brachial index to see if exactly what it is. And if it's less than 0.9, you have to start worrying about it and maybe get a vascular consult. So the initial thing, if it's open, is antibiotics is the emergency. And what is it? It's hey John, I'm in the middle of a conference. Can I call you back? Good. Can I call you back in in a little bit? Okay. Sorry guys. So ANSEF and Gent is if it's a dirty wound. Does anybody when do you guys use Gent? I'm just curious.
Any open fracture, I'll give him.
You do both, ANSEF, Gent?
Shot of gentamicin as well.
One side Gent in the ER. Okay. And the other thing I read is that the best way to give Gent is one dose a day. So apparently the gentamicin is only toxic in the trough. So, and it's most effective in the peak. So it's best to give 6 mg per kg per day. So, you know, a 70-kilogram person, it's a massive dose, but it's best to give a really high dose once a day. So I would probably just call pharmacy. And if there's a soil contamination, you need to use penicillin. So like Mark says, always want full length of the entire bone with both joints above and below. And if you have any question, you need arteriography or call vascular. So this is who uses the Synthes classification? Probably Doug, right? Probably the only one, right? Not even Doug. And then the Castillo-Anderson classification. One thing I learned from residency, it's not only the size of the wound, 1 centimeter, 10 centimeter, but the level of comminution, the energy of the injury, low, moderate, or severe, and the contamination. So if you have a pinhole, but it's extremely comminuted, it jumps up to a 3 immediately. So that's when Castillo and Anderson made their classification, that was a big point. But as you know, a lot of people just focus on the wound. So it's more than just that. It's the wound size, it's the comminution of the bone fragments, it's the energy of the injury. So the guy who slipped and fall was very low, but if it's a bumper strike, it's real high. So we just talked about that. 3 injuries, type 3 injuries, usually use you need soft tissue coverage. And there's another. Does anybody use this classification? Churn classification? I won't get into it then. And the problem with the classifications is that if you ask different orthopedic surgeons, they only agree 60% of the time. So it's not clear whether it's a very good classification. And the other important thing is compartment syndrome. So here are the 4 compartments. Bill, how do you do your fasciotomies?
Laterally.
Laterally? Just one incision?
Go down to the fibula and then go anterior and posterior to that.
You get all 4 compartments?
Well, I don't do them unless I measure them and they're high.
Mm-hmm. Okay, so when we were residency, remember it was like 45 millimeters mercury, and but since then it's like 30 millimeters. Within 30 millimeters of diastolic pressure is a better way to measure it. And obviously the clinical exam, pain. What do you guys usually use for compartment syndrome? Is there any use the exam or use the measurements? Use both, or how do you guys do measurements here?
Well, clinically, yeah, be highly suspicious for it. I think pain on passive stretch is a really good one. Pain out of proportion to the stimulus, unless you have a goofball.
Pain not resolved with morphine and pain with passive stretch?
Right. It's almost like nerve pain. You know, those guys that just can't get comfortable when they've got a...
Unconsolable pain.
Yeah. And then I use the striker.
You could use a striker or an art line, right? So the objectives of tibia fractures is no infection, cover the wound, make the bone heal, union, function, get the person back to their lives, and it may need multiple stages. So as far as timing is concerned, when we were 15 years ago, it was like within 6 hours. But apparently that's really not necessary if it's a clean wound. It just has to be done in a timely manner. There's really no benefit. It's not the emergency that it used to be. So just don't tell the anesthesiologist that, because we can still bump people for open fractures. They don't know that yet, but it's not a true emergency. It just has to be done in a timely manner. But if it's a dirty wound, obviously it's best to get the soil out as fast as possible. So the treatment of the soft tissue injury is meticulously debride it and get every single thing that you can out. And I think it's better not to do the pulse lavage at a high pressure. I think there's evidence that drives the contamination deeper into the soft tissues. What do you guys, Doug? What do you use when you have an open fracture? Do you have any? If it's a bad wound, what do you use?
For irrigation?
Yes.
I'll use pulse lavage. I use normal saline. I don't put any antibiotics in it.
How many liters do you use?
At least 3. If it's an open fracture, usually like 9.
Okay. Anybody do anything different? So I usually just use 9 liters, and I don't do it on the high thing. So we talked about pulse lavage, and then the other question is, what do you put in the fluid? Because the nurses, they're really aggressive about putting something in the fluid. They get really irritated if you don't put something in. So I just give up sometimes and just put whatever you want in there. But some people also put antibiotics in it. Some people put soap. Some people put iodine. Does anybody do any of those? So, and the other thing is bead pouches. Anybody bead pouch? I haven't put a bead pouch in a long time. I did when I was at GW. I put a number of them because I saw a lot of high-level injuries. But the bead pouches are a great way to put a high dose of antibiotics directly into the wound with either tobramycin or gentamicin. And if you can remember, it's 3.6 mgs of Tobra or 1 to 2 grams of vancomycin. So you can use either one that you want. And it's good for infections. And the other thing is, do you guys use wound vacs? So that's good negative pressure, but it doesn't deliver antibiotics. It's only negative. The other thing is, do you guys use them for wound infections? I did for a while, but the patients get really upset with it. They don't like carrying around the pouch. They really complain about it. And the other problem I've had with wound vacs is the nurses at home, they just stuff a huge sponge in it, and you can't get the wound to close because they keep stuffing this massive sponge in it. It's kind of like a reason to be. Like, their goal is not to get the wound to close, but rather how big of a sponge can you stuff in the hole. So you have to make it very clear,
Visits can they get out
Yeah,
of
the
the
visit.
house?
Yeah, they charge for visits. That's the problem. Is they don't have the same objectives as you. So that can be a problem too. So stabilizing the fracture is a very important goal. It reduces the infection, and your options are X-fix, nailing, or plate. So the advantages of the X-fix is you can put it on pretty quickly, and it's pretty straightforward. And then you can monitor the tissues and everything. Look at the wound. And what do you guys usually use? Use a uniplanar, I assume. Anybody here use go directly to the ring fixator? Just uniplanar. It's just very easy to put on, straightforward. And the technique is near, far, far. And if you have 4 pins, that's probably enough. I usually put 6, but I think 4 is adequate. Now, X-fixes, do they work? The union rate's pretty high, 95%, but the problem is there's a high malunion rate. So I think it wiggles a lot, somewhat, with the X-fix. So they become somewhat crooked. And if you take the fixator off too fast, the bone and is not healed, you will get a malunion. And the problem is the patient wants the fixator off because it's you've got this thing sticking out of your leg. It looks weird. So IM nailing is you have a much lower probability of malunion. You can walk on it right away, and you can start moving your ankle and knee, and it unites faster. And here's the insertion point, the sweet spot where you should insert your nail. Is just slightly lateral to the midline, just slightly lateral. And what do you guys use, Mark? What is your anatomical? How do you do it?
I just do an AP view and just get on that.
You approach it like an ACL, and go lateral to the patella tendon.
I do a medial.
Medial to the patella tendon, and then you just put it in there, and then you. Do you feel like there's a cartilaginous surface there where the sweet spot? So I always feel there, make sure I'm right on it. And then get an X-ray. Okay. So does anybody never ream? Is there anybody here who reams versus non-ream? So I always ream, but if it's a difficulty reaming, I don't ream like crazy. But I try to get a relatively large nail.
I think when the unreamed nails came out, it was kind of a fad for a while. Oh, I can do this without reaming. But I think that there's been evidence since then that shows that the reamings kind of act like graft at the site. And they're healing just as well. So
Right.
you get in a bigger nail if you're reaming.
Right, and so this is that. Then also, this is the main reason I think people initially didn't ream. That there was some evidence that you remove the endosteal blood supply from reaming. So you can see here on a ream nail, you remove the bone and you get some level of ischemia, and you can see if you don't ream the bone, the tibia has more vascular supply, higher vascular supply in the lab. But that hasn't been true in practice. So they've studied this prospectively, and there really isn't much difference when it comes to union rates. So I think as long as you don't go, my rule of thumb is that you don't go crazy on the reaming. You have a tiny person, you try to ream like up to 14, you're probably okay. So reaming an open tibia should be fine. You have somewhat of a deep infection rate, but probably not much different. And what do you guys use to reduce? How do you do your tibias? Bill, how do you do your tibias?
I do them almost all on the triangle now. Used to put them in the fracture table.
Ready, loose, and triangle, and you have Don Juan hold the foot, right?
I always ask for Don.
Yeah, well, that's the whole point. Is you need a good assistant.
Right.
So you can't do the triangle by yourself, right? Impossible.
You need a second person.
Yeah. So triangle with Don Juan. How about you, Doug?
Yeah, that sounds fine for nailing them.
Yeah.
Yeah.
Your technique, Don Juan and the triangle. How about you, Mark?
Triangle.
Triangle and Don Juan. Okay.
The McKay table at Hartford has actually got a really nice setup for if you're by yourself.
Traction.
That's what they have at Shock Trauma. We used to have it here, but they traded it out for some reason. But that's got a nice tibial setup with bent knee traction. And you can position the foot, reduce the fracture before you ever start the operation, and then it's slam dunk. It's a little more setup time.
We have it here. We can do it through the McKay. We have the capacity to do it here too. I mean, not our McKay. They're your table. What's it called? The Hannah table. I'm pretty sure can do it.
The headed table.
Yeah, I'm pretty sure we have the attachments.
Probably is the wood, hold the distal part.
We
Then
ha-
you can add
Yeah.
Don't we have a
It's
traction
really
bow?
distal fracture the boot.
We have a traction bow, guys. We have a traction bow and a K-wire. You can set it.
Calcaneal traction.
You can rig it up yourself. The problem is it's hard to get it going with the OR. How about you, Jack? What do you use for tibias? Triangle and Don Juan? Okay. So the other options are plate the fibula. So if you can just plate the fibula, it's usually completely reduced, but then you drive it into a little bit of varus sometimes. I use the femoral distractor because Don Juan is usually helping Bill Cook. So I put the distractor on the posterior to the tibia and in the calcaneus or the distal tibia, and it basically holds it for the whole case. And once you get your nail in, you take it off. You can also use a big clamp. This clamp is called Bill Cook's proximal tibia clamp, so he named it after himself. So you have to. That's how you have to ask. What? You have to ask for Bill Cook's proximal tibia clamp, and they know exactly what you're talking about. And you can also put a tiny unicortical plate if it's open, just to reduce the tibia, and then take it out or leave it in. That's like a trauma trick. Does anybody do that? I never do that. All right. So complications of nailing is infection, and apparently the word on the street from the Orthopaedic Trauma Association is if you get an infection, exchange a nail immediately. It will decrease your incidence of deep infection. So that's one thing I learned today, actually. And the union rate's very high, but the problem with nails is they get knee pain when they kneel. So that's a problem in Hartford County because we have a lot of church-going folk. But a lot of them are not Catholic, so I don't think, do Presbyterians kneel? I don't think so, right? It's just the Catholics that kneel. Huh? So I guess that's something you got to tell your Catholic folk or Greek Orthodox. And they have pain when they run. Sometimes they have pain at rest. So the other option is plating it, does anybody do subcutaneous plates here? I never do. I just don't have the level of testosterone to be able to do something like this. I just nail it or X-fix. But apparently these nails are good. The companies make a lot of money. And you can put them in subcutaneously. And here's a technique where you just open it on one end and then slide it down and do these little stab holes. But you have to reduce that. The problem of plating it is here you go. You get soft tissue disruption, deep infection, and then you got a serious problem on your hands. And then soft tissue coverage should be within 7 days or so. And we're kind of lucky. We have a plastic surgeon he likes to work until midnight, and he sees patient immediately, and he'll take care of business. So we're kind of lucky we have a very good plastic surgeon here. And the techniques are gastroc if it's high, soleus if it's middle, and then lower, it's usually a free flap or maybe a distal localized flap. And then bone grafting acutely shouldn't be done because it could get infected. And then bone morphogenic protein, it has been proven scientifically in a paper in JBJS. If that paper was true or not, it's unclear because the company has been investigated and it's been found to lie about their research.
OP1? OP1 was the first one.
OP1, but they also have an Infuse as an article.
Right, but OP1 was for tibia fracture. Now
Yeah.
It doesn't have FDA recommendations anymore.
Oh, really?
Yeah, so they haven't retracted the article, but they've sort of...
They backed off. And Medtronic, you guys know about Medtronic? that it was proven that they were that they withheld negative research about BMP and infuse. And who was it? Senator was it Grassley? Sent a letter, and they're investigating Medtronic. And Medtronic gave $1 or $2 million to Yale to investigate the whole thing, but BMP has dropped down dramatically in the use of spine, which is the biggest use. I can go over that. I have a whole lecture on that if you guys are interested, because I'm interested in it. So gunshot wounds, we don't get a lot of these, thank God. But if it's a low energy injury, which is usually what happens in Harford County, somebody like Jack shoots somebody who yells at him or something in the back, huh?
Road rage.
In the back in Looney's parking lot. Yeah, you can treat these like a closed injury, apparently, just antibiotics. What would anybody? I usually take them to the OR, wash it out, and excise the wound. Do you guys do anything differently? Treat it with antibiotics, or we don't even see it here, right? I've never seen a gunshot wound here. Yeah, we don't get them. They usually sent to shock trauma too, probably.
For a 22, I'm not even sure if you need to treat them with antibiotics for a low energy fracture, upper extremity or something. I think that's fine.
It's not so much a gunshot as it is what they take in with it.
Yeah, a piece of pants.
Yeah.
Some clothes, take a shirt.
Yeah, clothes.
Right, and there were two big studies that were done. One was done in Minnesota and one was done in Miami. And in Miami, they had a much lower rate of infections when they treated them non-operatively than Minnesota. But if you look closer, you realize that in Minnesota, these were like hunting accidents. And these guys all had down jackets on, and where they'd get all this crap sucked into the wound. Whereas in Miami, everyone was running around half naked.
Shorts and sandals, yeah.
Shorts and slippies. And so they never got infected anyway. So
right.
The literature was really all over the place.
Right.
It's probably 22s and 357 as opposed to shotguns.
Right.
Okay, so other problems with are non-unions, malunions, infections, fatigue fractures, and hardware failures. So non-unions, my definition is usually 6 months. That's a long time to deal with something. And if it's not healed by 6 months, I think something should be done. But do you guys use anything different for non-unions? I mean, how long do you expect this poor person to have pain? It's kind of like inhumane to have someone have constant pain in their leg. I think after 6 months you got to do something.
For tibia fracture?
Yeah.
Supposedly the definition is no radiographic change over a 3-month period.
Okay, I mean that's probably reasonable.
Like if you see just a little bit, even if it's just a little bit, then it's quote something's happened.
Mm-hmm. So if at 3 months you've got absolutely nothing, you should probably do something. So the options are onlay bone graft substitutes. We talked about BMP, free vascularized bone grafts, which I'm not sure if that's a long run for a short slide. A reamed exchange nailing, which is very easy. Compression plating or Lizaroff.
How about bone stimulators? Anybody automatically put bone stimulators on?
That's an option. Yeah. Does anybody use bone stimulators here?
I
Do you?
would probably use that before I did one of those.
A Lizaroff? Yeah. Sure. No morbidity involved. So malunion, it can be a problem in the tibia, and I think I use 5 degrees. I think that's what most people use, and it's an osteotomy, which is a problem in the tibia. So you'd have to. It's hard to get the tibia to heal. The other thing these patients get are fatigue fractures. So you have them start to walk on this osteoporotic foot that hasn't walked in 6 weeks, and they can get calcaneus stress fractures, metatarsal stress fractures. So, bone scan with diagnosis or an MRI. The implant can fail if the bone's not going on to heal. And then the treatment is you can do nothing and then watch it or remove them. And then the big question is when you have a very bad injury, do you even attempt to salvage it, or do you go straight to amputation? We don't do this sort of thing here because we're not a high level 1 center. And but when you do an amputation, I used to do them at GW. I did a lot of amputations. You get a second opinion from another orthopedic surgeon, and probably a second opinion from a general surgeon, or I would get a vascular surgeon and see what because they do they do all the amputations here anyway. And I don't know about you guys, but I photograph everything now. So I have an iPhone. I think every single one of us, even Bill Cook, has a smartphone now. So
Doesn't know how to use it. But it looks great.
Yeah, he looks at X-rated sites with it. That's about it. So if you look at my iPhone, I've got pictures of my kids, pictures of the naked women that Eric sends me on the internet, and pictures of all my patients. So I have these lumbar wounds, these infections, the injuries that I see. I just take a picture of everything, and then it's part of the medical record basically. And especially someone who is a bad wound, or someone who comes in the office and you're worried about it a little bit, you start on antibiotics, culture it, open the wound. I snap a picture of it too, and then when they come back the next week, I look at it and I show the patient. So I think it's a great thing to do now. If you see a bad wound, trauma injury, you may want to grade it with the mangled extremity severity score, and that kind of just gives you a number. It has to do with the soft tissue injury, if it's ischemic, if the patient is shocked, and how old the person is. And basically, the 4 Ds, if you should salvage the limb, are disabled, destitute, drunk, and divorced. So those are 4 risk factors for a poor result with a reconstruction versus go straight to an amputation. But some people, amputations can do quite well, especially below knees. And the LEAP study prospectively looked at these people, whether to reconstruct the leg or do a amputation. And they found that people, they amputated or they reconstructed, it was mostly done because what the patient wanted. And it had nothing to do with insensate limb or the mangled extremity severity score. So I think it makes sense when somebody comes in, they don't want you to, he's like, don't cut off my leg. And they may have a mangled extremity score of, whatever, a terrible, or they have a totally insensate leg, but they say, I don't want my leg cut off. So usually the orthopedic surgeon, I think, is handcuffed by what the patient wants, which, makes sense. And it's not clear, with the LEAP study, it's not clear who did better, but the people who reconstructed the leg needed multiple surgeries and long hospitalization, which is obvious. So I don't know. I don't think it's a straightforward decision-making process. Does anybody have any questions about that or any comments? We don't deal with that really here. Okay. So the outcomes when they studied it on the LEAP studies were mostly associated with how bad the soft tissues were and the neurovascular bundle if it was injured. So those are the most predictive factors when it comes to result. In early soft tissue coverage, the patients did better. Okay, so let's go over another case. Doug, this is a 21-year-old man who was in a motor vehicle crash. How would you treat him? 21 years old.
I might give consideration of putting a spanning ankle external fixator on him. Maybe put some pins in his tibia, pins in his calcaneus, and just sort of he's almost in pretty good position.
Okay, let's do these in steps. So you're going to span the ankle.
Yep.
Within an X fix.
Yep.
And then, is that it? What else are you going to do?
This guy on the lateral, it looks like the fracture goes into the joint. It looks like his distal tibia is off.
Look at the lateral view. The tibia is definitely fractured there. See how there's
so
a
I
coronal
might consider
fracture.
some type of minimal internal fixation. Put a screw or two in his distal tibia also.
Okay, would you plate the fibula?
Probably not.
Okay. Anybody? I would do something different. Anybody do anything differently in this case? And then maybe get a CAT scan and see what you have afterwards, right?
Definitely re-image and CAT scan or something and see if I can reconstruct it.
Post-op.
But
Okay.
I think that the whole deal is trying to get his distal tibia articular surface fixed.
Give him a good ankle and a normally aligned tibia. Huh?
Put a little plate on that fibula, and then
Yeah, that's how I would differentiate from
start
the.
off from there, and then I think you have to. Then you can straighten them out a little bit, and then that posterior fragment of the tibia probably will come down, and you can put a screw across it, and then pull it down and put it in.
Maybe a front to back screw or a back to front screw. Yeah.
And then I'd have to see what the rest of it looks like, whether plated or.
Yeah. Yeah, the only thing I would differ in that is I would plate the fibula first because that may reduce your ankle joint, and then put a couple percutaneous screws, like you said, to fix the ankle joint, and then span it with an X fix, and then get a CAT scan and see what you have. And maybe that's all you need to do for this guy. Okay. Anybody do anything else differently? Okay. Yeah?
Just as a thought, you know, you talked about varus and valgus. You know, they do better with varus or valgus, things like that. It's also, you know, flexion extension, where you have the some of the tibial deformities. You know, it's posterior or anterior. You know, they do better with posterior.
Procurvatum versus recurvatum? Okay.
So I think that's some of the complications I've seen have been because of that, as opposed to varus valgus.
Mm-hmm. Definitely. So in this case, this is not my case. I got this from the Orthopaedic Trauma Association website. They did something very similar. I mean, look at that ankle. It's like perfect X-ray. So they basically did what we said plus nail it. But I would probably nail it on a staged manner, like do what we said and then take the X-fix off and then nail it in a staged manner. Let the soft tissues be out of the woods, so to speak, in like 48 hours. All right.
These
Yeah.
3 plates for the feet.
Yeah. You know, trauma surgeons, they like to use multiple plates. They use these tiny plates. That's in vogue now. I'm a spine surgeon. There's one plate. That's it. I can't do anything more complicated than that. But do you guys use the multiple plates?
You know, it's really rare. You usually put multiple plates on if you can't get it with one. I mean, I think I've used multiple plates like 2 or 3 times.
Well, these trauma centers, they have these fellows that are smart guys, energetic, they're gangbusters.